Assalamu alaikum. Let's dive into the second part of the pediatric gastroenterology. Start with this exciting topic, crying in young infant. Normally, normal, intermittent, consolable, less than 3 hours of cry. If there is colic, there is more than 3 hours of crying, more than 3 days per week. So 3 hours and more than 3 days, 33. And healthy infant age less than 3 months, so 333. And colic A B C, so C, colic is more than 3 hours of crying, more than 3 days per week, and healthy infant age less than 3. And A B C. Okay, GRD. This one, this 2 point is very high. Frequent spit up and back arching after feeding, back arching after feeding. Okay, now infection, acute otitis media, there may be meningitis, there may be septic arthritis, there may be UTI. In acute otitis media, there may be bulging tympanic membrane. Tympanic membrane erythema alone is of not diagnostic with or without fever. There may be meningitis, there may be septic arthritis, there may be UTI, and go according to its own clinical feature. Now, intussusception, very high yield, episodic, irritability with legs drawn to the abdomen. This word is very high yield. Episodic, irritability with legs drawn to the abdomen. There is either without bilious emesis with or without bilious emesis and bloody stool. Torsion, testicular torsion or abdominal distension. It can come with crying in young infant. So testicular torsion or abdominal distension, like ovarian torsion, can happen. And the trauma, hair tonic with hair accidentally wrapped around the disease. These type of crying infant comes also in the outdoor basis. And corneal abrasion, tearing, photophobia, fluorescent test, and abuse or fracture, bruising, laceration, asymmetric movement, bruising, laceration, asymmetric movement. Acute otitis media can present with irritability plus a bulging tympanic membrane. Acute otitis media can present with irritability plus a bulging tympanic membrane or a middle ear effusion with tympanic membrane inflammation, erythema. Tympanic membrane erythema alone is not a diagnostic of this condition. Colic. Okay. So differential diagnosis of the regurgitation and vomiting of the infant. One is GRD. It may be physiological, it may be pathological. Physiological, asymptomatic, they're happy, spitter, reassurance, and positioning therapy. And pathologic like GRD, failure to thrive, significant irritability, and Sandifer syndrome. Uh, Thickened fits, antacid therapy if severe, esophageal pH probe monitoring, and upper GI endoscopy. Milk protein allergy, there may be regurgitation, vomiting, eczema, bloody stool, elimination of the daily soy protein from the food, and pyloric stenosis, projectile non-bilious vomiting, olive-shaped abdominal mass, dehydration, and weight loss, abdominal ultrasound, and pyloromyotomy. GERD is common in infant due to shorter esophagus, incomplete closure of the lower esophageal sphincter, and greater time spent in the supine position. Physiologic GRD and the GRD pathogenesis, immature lower esophageal sphincter, spit up, normal weight gain, no pain or back arching. Management is upright positioning after feeds, burping during feeds, and frequent small volume feeds. The majority of the infants experience a GERD. However, those exposed to tobacco smoke, which reduced esophageal sphincter pressure, are at increased risk. Most infants are otherwise asymptomatic. Happy spitter feels comfortable after burping, and patients should be reassured if examination, growth, and development is normal. Treatment consists of education and supportive measure. Patients should be advised to give frequent small volume feeds, hold the infant upright 20 to 30 minutes after feeds, and place the infant prone when awake. Prone with sleeping can increase the risk of prone or when awake. Prone while sleeping can cause can increase the risk of sudden infant death syndrome. Okay, now this is a very high yield box. We need to remember straining infant if there is ill appearing or red flags present, like serious organic cause, Hirschsprung disease, spinal dysmorphism, HSC, Hirschsprung disease, hypothyroidism, spinal dystrophism, and cystic fibrosis, ill appearing or red flags present. And red flags includes like severe abdominal distension, abnormal rectal tone found in Hirschsprung disease. Severe abdominal distension may be found, and sacral findings found in spinal dysraphism, delayed passage of the meconium, and failure to thrive. It can found at hypothyroidism. Okay, if the baby is well appearing, loose stool with or without mucosal blood, food-induced protein enterocolitis, normal stool consistency, normal infant dysphagia, hard or pellet-like stool, functional constipation with or without anal fissure if blood is present. Infant dysphagia, uh, painful defecation. Pathogenesis of infant dysphagia involves failure to coordinate increased intra-abdominal pressure with relaxation of the pelvic floor muscle, inadequate abdominal muscle tone to produce an effective valsalva. The mechanism results in characteristic findings of crying, turning red in the face, and straining for greater than 10 minutes, followed by a passage of non-bloody stool. Soft, non-bloody stool. As the infant's guts or nervous system mature, defecation becomes more coordinated, and infants disengage a painful defecation resolves spontaneously, typically by the age of 9 months. So you need to episodes may be concerning to patients, but management includes providing education and reassurance. Switching to soy formula can be considered for straining from food protein-induced proctocolitis due to milk. Okay, now pediatric constipation. Pediatric constipation, initiation of solid food and cow's milk, initiation of solid food and cow's milk, toilet training, school entry, clinical feature, painful hard bowel movements, stool withholding, and encorporasis like fecal incontinence. Complications are anal fissure, hemorrhoids, and anuresis. Anal fissure, hemorrhoids, anuresis. Treatment: increase dietary fiber and water intake. Limits cow's milk intake to decrease 24 hours. Laxative with or without suppository or enema. If all treatment fails, the anorectal manometry to rule out the Hirschsprung disease. Now pediatric constipation. In pediatric constipation, it may be pathological, it may be functional. Pediatric constipation, it may be pathological, it may be functional. Pathologic delayed passage of the meconium Down syndrome. Delayed passage of the meconium and the Down syndrome. Functional is solid protein introduction, toilet training, school entry. Pathologic is delayed passage of meconium Down syndrome. Functional is solid food introduction, toilet training, and school entry. History in pathologic: poor weight gain, blood mixed in stool, and bilious emesis. Poor weight gain, blood mixed in stool, and bilious emesis. And the functional is absence of pathologic feature. There may be painful, infrequent, large caliber pellet-like stool, and there may be fecal swelling. Encorporesis. Examination is displaced anus, increased rectal tone. In pathologic cause, displaced anus, increased rectal tone, sacral abnormalities, tuft of hair found in spinal dysgraphism. There may be abnormal lower extremity neurologic finding, weakness, severe abdominal distension. And in functional case, absence of pathologic features, mild abdominal distension, anal fissure with or without rectal bleeding. Management for physiologic common celiac disease, hypothyroidism, and urgent Hirschsprung disease, cystic fibrosis, and dysraphism. Hirschsprung disease, cystic fibrosis, and spinal dysraphism, and the celiac disease and hypothyroidism. And functional is age-appropriate toileting plan, dietary changes, increased fiber and water, laxatives. Cyclic vomiting syndrome. Cyclic vomiting syndrome, personal or family history of migraine episodes often have identified trigger, infection, stress. Stereotypical vomiting episodes, acute onset nausea, vomiting, abdominal pain, headache, self-limited within 1 to 2 days, and between episodes usually asymptomatic, often regular interval 2 to 4 weeks. Abortive is tryptophan and supportive like anti-emetic rehydration. These and that. Marijuana is a major risk factor in the absence of known medical benefit. Preventive therapy includes amitriptyline age more than 5 and cyproheptadine, amitriptyline and cyproheptadine. Okay, common association meconium ileus associated with cystic fibrosis which causes chronic sinopulmonary disease. Hirschsprung disease is associated with Down syndrome, increases the risk of early onset Alzheimer's disease and hypothyroidism. Um, Early onset Alzheimer's disease and hypothyroidism. Bicuspid aortic valve is common in Turner syndrome, which is associated with increased risk of inflammatory bowel disease. A diaphragmatic hernia may be an isolated anomaly or associated with trisomy 18 Edwards syndrome. Duodenal atresia is commonly associated with trisomy 21. Bacterial syndrome. Holoprosencephaly is associated with trisomy 13. Tau syndrome. Reye syndrome. Pediatric aspirin use during influenza or varicella infection. Pediatric aspirin used during influenza or varicella infection. Acute liver failure. Encephalopathy, cerebral edema. Increase ICP. Increase AST, PTINR, PTT, and increase ammonia. Biopsy is microvascular steatosis on liver biopsy in the context of Acute hepatic encephalopathy is consistent with Reye syndrome. Support Despite liver damage, bilirubin is usually normal. Patients should be reminded that aspirin is generally contraindicated in children, except in Kawasaki disease and other rheumatologic JIA. You can give aspirin. So diagnosis should be done. Alpha-1 antitrypsin deficiency is characterized by chronic liver dysfunction and childhood, followed by emphysema and later in life cirrhosis and periportal eosinophilic inclusion bodies are typically seen on liver biopsy. This is the picture of the Reye syndrome where there is all the liver enzyme, acute fatty liver failure, ASCLT, APT, INR, ABTT, everything is IMNA is high. This is intussusception, ileum telescopes into the cecum. Ileum telescopes into the cecum, pain, obstruction, edema, compression of the blood vessel, bowel ischemia, and rectal bleeding. Now intussusception. Intussusception risk factor is recurrent viral illness or rotavirus infection, pathological lead point, congenital malformation of the intestine, Meckel's, intussusception, pathologic lead point, Meckel's diverticulum, Henoch-Schwann lens, celiac disease, intestinal tumor, polyp. Sudden intermittent abdominal pain, current jelly stool, sausage-shaped abdominal mass, lethargy or abdominal lethargy or altered mental status. Diagnosis is target sign or two concentric circle on ultrasound. X-ray can show soft tissue mass in the right upper quadrant or a quiescent sign, which can represent the intussusceptum projecting into the large wall. AR or saline edema and surgery. If enema reduction is ineffective, if a pathological lead point is identified, or if a patient has signs of perforation, and intestinal emergency most common in children aged 3 to 6 months, not in newborns. Uh, The ileocolic junction is most frequently involved with the invagination of the ileum into the colon. Although ileocecal junction is normally located in the right lower quadrant, the invagination of the ileum into the colon often causes mass to the profound right middle and upper abdomen. Most patients have no identifiable lead point. A pathologic lead point, a recurrent intussusception, atypical age, atypical location, recurrent intussusception, atypical age for intussusception, and atypical location for intussusception. Intermittent contraction of the telescoped bowel during peristalsis results in classic presentation of the episodic inconsolable crying with legs flexed and drawn into the abdomen followed by asymptomatic period. Emergency intussusception, colon wall, colonic lumen. This is the ileum, colon lumen, colon wall. This is the target sign. This is the crescent sign, intussusception. Open colonic segment, invaginated distal small intestine. Now, juvenile polyp typically present in children aged 2 to 10 with painless rectal bleeding. Now, Meckel's diverticulum, rule of 2% prevalence, presentation often age by 2:1, and location 2 feet of the ileocecal valve. Clinical presentation may be asymptomatic, incidental finding, painless lower GI bleeding, anemia, and complication for Meckel's is intussusception, volvulus, and intestinal obstruction. In symptomatic patients, surgical resection to prevent further bleeding or complication. Malrotation with midgut volvulus. Malrotation with midgut volvulus, failure of the embryonic gut rotation. Narrow mesenteric base allows increased small bowel mobility. twisting of the small bowel around the superior mesenteric artery, and gut ischemia and necrosis. Gut ischemia and necrosis. Most common in infancy, usually age less than 1 month. Acute bilious emesis, abdominal distension. Chronic is intermittent abdominal pain, vomiting, failure to thrive, untreated hematochezia, peritonitis, shock. Abdominal X-ray, they are dilated bowel, air fluid level, pneumoperitoneum. Upper GI series, gold standard. Duodenal bird, beak or corkscrew appearance, ligament of Fraze on the right, abnormally located. Emergency laparotomy to relieve volvulus and Ladd's procedure. Bilious emesis can due to severe etiology, intestinal atresia, midgut volvulus, meconium ileus. This is the picture of the midgut volvulus, contrast in esophagus and the stomach, and corkscrew appearance of the small bowel volvulus. Now sigmoid volvulus, sigmoid colon redundancy, dilatation or elongation of the chronic constipation, elderly age, chronic dysmotility, especially hypomotility, underlying neurological disorder. Sigmoid volvulus, abdominal discomfort, distension with or without obstructive feature, imaging, X-ray, dilated inverted U-shaped colon, U-shaped loop of the colon, dilated inverted U-shaped loop of the colon, colon bean sign, and CT scan show dilated sigmoid colon and mesenteric twisting, Worrell sign. Management is endoscopic detorsion, flexible sigmoidoscopy, elective sigmoid colectomy. Management is emergency sigmoid colectomy with if perforation or peritonitis present. If perforation or peritonitis is present. This is the okay. So this is the midgut volvulus, and this picture is the cecal volvulus. There is dilated air loop of the colon and normal descending and the sigmoid colon. Normal descending and the sigmoid colon. So it is not sigmoid volvulus. So this is cecal volvulus, dilated air loop of the colon, but normal descending and the sigmoid colon. In here, look, there is contrast in the esophagus and the stomach. This is the picture of the midgut volvulus. Okay. Paralytic ileus. Paralytic ileus typically causes generalized distension of the large or small bowel on X-ray. Intestinal obstruction due to dysfunctional peristalsis. Toxic megacolon can cause a colonic dilatation of the X-ray, and X-ray typically reveals diffuse dilatation of the colon within the normal anatomic arrangement rather than a single dilated colonic loop in the cecal volvulus. This is cecal volvulus, and this is coffee bean shaped inverted U-shaped sigmoid volvulus. This is again cecal volvulus. Look closely with the magnifier. Mesenteric twisting. This is the Worrell sign. Mesenteric twisting. Worrell sign in the right lower quadrant, and there is a dilated air filled sigmoid, dilated air filled segment in the colon, dilated air filled segment in the colon, normal descending colon. So small bowel obstruction, this is a small bowel obstruction on the X-ray, proximal small bowel dilatation and small bowel air fluid level, small bowel air fluid level. Okay, now soft tissue opacity with internal air mottling, soft tissue opacity with internal air mottling. This is a soft tissue motility. This is large bowel with filled with feces, large bowel. This is large bowel filled with feces. This is normal gas, large bowel gas pattern. This is normal large bowel gas pattern, and this one is large bowel soft tissue opacity with internal layer. There is internal layer, there is soft tissue opacity. Large bowel with feces. This is a picture of the toxic megacolon. There is dilated colon. Colon is dilated. Look at this picture. This is normal, and there is paralytic ileum, gastric dilatation, dilatation of the large intestine, and dilatation of the small intestine. Look here, dilatation of the small intestine, dilatation of the large, gastric dilatation. Ileus on abdominal extra. This is small bowel dilatation. This one is large bowel dilatation. Okay, now the CDH, congenital diaphragmatic hernia. CDH, congenital diaphragm, incomplete fusion of the pleuroperitoneal fold, incompletion. There is herniation of the bowel into the chest. Pulmonary hypoplasia and pulmonary hypertension can present. Respiratory distress, tachypnea, cyanosis, retraction within hours after birth, absent breath sound, ipsilateral to the defect, concave abdomen, chest x-ray showing intrathoracic bowel loops and displaced cardiac shadow. In CDH, congenital diaphragmatic hernia, endotracheal intubation, gastric decompression, and surgical correction. Chest X-ray is diagnostic for CDH. Is not detected prenatally. Lack of prenatal care. CDH is endotracheal intubation. Bag mask ventilation is contraindicated. Very high. Bag mask ventilation is contraindicated because it pumps air into the GI tract, leading to further lung compression. As it pumps air into the GI tract, it can cause further lung compression. So bag and mask ventilation is contraindicated in CDH. Congenital diaphragmatic hernia, nasogastric tube. This is the fundus. This is the chest tube. Uh, Gastric curvature of the stomach. Okay. Paraesophageal hernia, retrocardiac air fluid level. Paraesophageal hernias. It may also be seen in sliding hernia. The diagnosis is confirmed by barium swallow or upper GI endoscopy. Sliding hernia occurs due to the laxity of the pharyngoesophageal membrane. This allows the gastroesophageal junction and proximal stomach to slide into the thoracic cavity. There is retrocardiac opacity. Asymptomatic patients require no further evaluation beyond observation. Patient with reflux symptoms should be medically managed, and those with refractory GRD symptoms can be considered with anti-reflux surgery, missions, fundoplication. This is hiatal hernia, air fluid level. Okay, femoral hernia, rectus sheath hematoma. Okay, femoral hernia, risk factor chronic cough, constipation. Oh, usually seen in the older woman. This is not pediatric issues. Rectus sheath hematoma, it is also happening in older age female sex. Rectus sheath hematoma, there is anemia, leukocytosis. Rectus sheath hematoma due to rupture of the inferior epigastric artery. Abdominal CT scan to confirm. This is very high for the pediatric. Suspected foreign body injection. Is suspected foreign body injection, PA and lateral view. CT scan if object not visualized on PA and lateral view. High risk feature, endoscopic removal. No high risk, serial X-ray. No high risk, serial X-ray. No transit, endoscopic removal. Object moving distally, no intervention. Object moving distally, no suspected foreign body injection, PA and lateral view. High risk feature, endoscopic removal. No high risk feature, serial X-ray, no transit of endoscopic removal, and object moving distally, no intervention. If sharp foreign body is distal to the proximal duodenum, is asymptomatic patient, observation, repeat X-ray 12 to 24 hours. Magnets identified beyond the stomach can be removed via colonoscopy or followed by serial X-ray every 4 to 6 hours. If symptoms, abdominal pain, GI bleeding develop, often if the magnets do not progress in the GI tract, and surgical removal is indicated. Radiographic feature the distinguished bilaminar structure button battery from a flat coin. This is very high. Button battery from a halo or double ring around the circular object on AP view, and a step of or beveled edge on the lateral view. Step of or beveled lateral halo or double ring in the circular objects, like button battery from the emergency endoscopic removal. This is button battery. Coin button battery on lateral, step off or beveled edge on the lateral view. In the lateral view, step off and beveled edge, and the in the PA view. In the PA view, there is a hollow or double blind. An asymptomatic patient who ingested a small blunt object coin may be observed with repeated X-ray after 24 hours to confirm progression of the object beyond the stomach. This is battery. This is in the esophagus. This is in the trachea. If it is in the esophagus, then it can go into the stomach, and then easily pass through the stomach. Okay, there are plenty of things in the pediatric gastroenterology. Okay, I think that we have passed through the pediatric part of the gastroenterology. Hope you enjoyed.